So first of all, thank you very much, Dr. Gaurav, for this masterclass, and it was actually um, so much of information, concise, very crisp, and uh, and more importantly, more practical aspects of and your own data. I'll request you to stay back, and I will request Dr. Raghu, who is a senior consultant, pediatric hematology oncology at the prestigious Tata Medical Center at Kolkata. So he's going to discuss some of the more practical aspects with regards to the same topic. And I introduce Dr. Raghu for the audience, and also Raghu, if you could introduce your panelist and start the discussion. Thank you very much.
Thank you. Is it visible? The slides are visible?
Yes, we can see your slides.
Oh. So after that illuminating talk by Dr. Devar sir, we will move on to some of the challenges that we face practically when we are taking up the patient for transplant. During the pre-transplant phase, when you are working up for transplant, as well as during the bridging therapies. So in this discussion, we have three panelists. Dr. Devar sir is continuing in this panel as well. We have Dr. Sandeep Jain from Rajiv Gandhi Cancer Institute, Delhi, and we have Dr. Virendra Patel, Baswa Taragam Indoor American Cancer Center, Hyderabad in this session. So I will begin this session. We have about 30 minutes left. So maybe a couple of questions to each panelist. The first question is to Gaurav sir himself. The question is that you had discussed about the importance of MRD, how critical it is in the bridging therapy and decision for transplant. But we also highlighted the problem that we face in terms of standardization of MRD. And sensitivity of MRD using various techniques is also increasing day by day. So in this, what is the basic minimum that you would expect in terms of MRD assessment before we take a patient for transplant?
Yeah. So I think I covered some of that in the talk itself. Yeah. So basically, you need high sensitivity flow, and you need more markers because of what, and especially considering the kind of therapies which we are giving the patients prior to taking up for transplant. So uh, whether you use chemo alone, whether you use CD19 directed therapy, whether you use CD22 directed therapy, your flow has got to be advanced and sensitive enough to pick up disease in the absence of these markers which you have knocked out with your immunotherapy. So, so if your gating strategy is based on CD19 gating, you're going to miss CD19 negative disease, which could be there because you knocked out the CD19 positive disease with your CD19 directed therapy, either blinatumomab or CAR-T. Same goes for CD22. So when we don't have CD19, we use CD22 and gating first. And if you're giving a patient anituzumab in the past, they may CD22 may be knocked out, and the patient may not be having any CD22 positive blasts, but they may be CD19 or CD other expressions there in the uh, marrow, which might be expressed on the blast. So that's why I showed you a paper where we use a hierarchical grading strategy of 5 different gates, which are used hierarchically to ensure that you don't miss a blast population. So that is about the sensitivity of being able to pick up blasts which may not be expressing the markers, which especially because of the therapy you've given pre-transplant. Now we are getting patients who are coming for transplant post INO, post CAR-T, post Blina. So you're getting, so we are getting those combinations also now. So your flow has to be sensitive enough with multiple hierarchies in your gating strategy to be able to pick up your blasts. The second issue that comes up is that sensitivity. The second has to be depth uh, and the ability to pick up mimics. So that's why what I showed you the data was for post CD19 therapies. I showed you that flow strategy also that we have developed, and now it's published and is being used by others also. And also I showed you the mimics and the false negativity both, or how they can be missed. That is just with chemo alone. You don't need to have these immunological targets. So that is sorted by using more parameters. So 15 floor multi-parameter flow cytometry with hierarchical gating strategies is the minimum I would say should be required these days for transplant centers.
Thank you, sir. Next question is to Dr. Sandeep Jain. So we have discussed about various bridging therapy options available, including Blinacimab and Blinacimab CAR-T. However, this remains out of reach for the vast majority of the patients, and the programs, humanitarian programs for Blinacimab access is available only at direct centers. So in this situation, for bridging or inducing remission to satisfactory level in patients, what are the options available in a resource-limited center?
Thank you, Raghu, for the question. I think this is not an uncommon situation in our setting when we have a patient with relapse or refractory leukemia and the patient doesn't have access to immunotherapy such as Blina, INO, or CAR-T. I would say the first and foremost thing in this situation is to sit with the family, apprise them of the clinical condition of the child, the salvage options that we have, and what lies ahead. They should have realistic expectation, and the treating team and the entire family should be on the same page. Now, if we talk about the salvage regime, let's talk about the AML first. We have to understand that this is relatively a smaller subset compared to ALL, but with a much more clinical and biologically heterogeneity. Therefore, it is not surprising that we don't have very large study where we have like approval or refusal of one option over the other. The option that has been most widely tested in Europe in the largest study is liposomal daunorubicin with or without flag. And in this study, actually, the patient, those who received liposomal daunorubicin with flag has somewhat better outcome compared to those who received only liposomal daunorubicin. But again, this was mainly for core binding factor leukemia. If we talk about the options that we have in our setting, one option can be again reinduction with 3+7. But in this, we have to actually assess the cardiac status because this patient had received daunorubicin in the past. And a paper from AIMS by Dr. Samir Bakshi has shown that this 3+7 again has given a decent negativity, morphological remission and MRD negativity at the end of induction. The other options include flag with or without anthracycline. If the general condition of the patient is not good, azacitidine with venetoclax may be another option that we can try to give to achieve remission. Now, coming to ALL, I think Dr. Gaurav has covered it nicely. For most of the patient with ALL, either we can give again 4-drug induction. Most of the centers in India are using BFM REJ 2002 protocol. UK ALL R3 protocol is another option. For T-ALL, we may add bortezomib, or we can use a nectar regime, which include nelarabine with cyclo and etoposide. And in certain subset of patients, venetoclax and dasatinib can also be added. But having said that, the most important thing is whatever salvage regime we use, our ultimate aim is to achieve a decent remission, preferably a negative MRD status, and then subject them to allogenic bone marrow transplant.
So even without these advanced drugs which are available now, we should bank on our conventional chemotherapy, at least for a select group of patients.
So basically, the question was in absence of access to Blina and INO and CAR-T, then these are the conventional options. But things have changed, as Dr. Gaurav has shown. The things are moving very fast. This is in absence of access to newer therapies.
Okay, thank you. Next question is to Dr. Virendra Patel about the extramedullary disease, both in ALL and AML patients. This is a specific area which need to be tackled before transplant. So how do you go about it in your experience?
Yeah, good evening to all. So this is a real challenge when we actually can't anticipate doing transplant as a consolidation therapy for children with this leukemias. As you know that the basic dogma states that you need to get the disease as much as possible, in depth in remission before you go out with transplant. So getting getting the disease under control for this extramedullary disease is really tricky, and it differs between ALL and AML. In ALL, it is very straightforward that you come across a good number of patients having extramedullary disease in two sites, especially in CNS and testicular, what we say that is sanctuary sites. So sterilizing those two sites before transplant is very important that to get the disease in long-term remission, because getting just changing the hematopoietic stem cell hematopoietic system doesn't give you immunity against these extramedullary sites if they are actually loaded with. So there are so many ways of getting these extramedullary sites in ALL sterilized before transplant that by doing good induction chemotherapy, you get, if the disease is responsive to the chemotherapy, you get the disease under remission. And also you can use specific targeted therapies like CNS directed radiation for CNS disease, and for testes, you can probably consider surgery if it is unilateral, and probably radiation therapy as consolidation before you go to the transplantation. And coming to AML, most of the times when it comes to extramedullary disease in AML, it is myeloid sarcoma, and also the second part is CNS involvement of AML disease, which is difficult to address with. Myeloid sarcomas, most of the patients do respond to the chemotherapy, and if they respond, that's great. If they don't respond, then probably the options which are left are probably can consider local radiation therapy or surgery in refractory conditions, which is very rare to see. And most of the times they do respond to this, chemotherapy, traditional chemotherapy, or probably some of the newest, way of treating them with azacitidine and venetoclax, which has got good response to this. And in CNS disease in AML, of course, it need to be treated with triple ITs and intensive chemotherapies that would clear the disease, and then post that probably can consider for transplant. So some of the things which can be kept in mind before doing transplant for these patients with extramedullary disease or CNS3 disease or testicular disease are this, that so there are some articles which have been published to show that if you consider CNS boost before transplant, if you're planning for TBI, you can integrate with that, doing transplant with CNS boost to the dose of 6 grays to even some of the articles have used 10 grays, and shown that they have got some benefit in EFS and OS in patients with CNS positive diseases. So that could be one, modality for using these patients, taking these patients for transplant. And in AML, in myeloid sarcoma, you can also be considering a post-transplant consolidation with radiation if there is, persistent activity or disease recurring.
Virusa, I had a doubt. How effective are CAR-T and Blina in this situation, clearing extramedullary?
For me?
Yeah.
Okay. So Blina and extramedullary disease is the easier one to address first, not very effective. And secondly, for CNS especially, it is neither effective, and in fact, it can contribute to neurotoxicity. So you should ideally have cleared CNS, and even if they have had past CNS disease and no neurological sequelae, there's a slightly enhanced risk. But if there's any neurological sequelae, neurotoxicity is likely. We have burnt our fingers, so we use this in patients, and then we had to discontinue. So then it becomes a waste of a drug also. So this is something which you should avoid. So if there's active CNS disease, definitely clear it. And this principle applies for CAR-T also. Real world data with Tisandic Lactucell and others has shown effective clearance of CNS disease with CAR-T, even with active CNS disease. But all of them in those trials and in the data, the neurotoxicity rate is around 20 to 47%, depending upon which CAR-T and which trial and which data you're looking at. That's quite high. And if you manage neurotoxicity in CAR-T, you'll realize it's quite distressing. Even though most of the time, it recovers. So, but CAR-T is different. You're given it. If neurotoxicity occurs, well, you have to deal with it because the CAR-T is floating around in the body. Blina needs to be stopped if you get seizures. And if they get seizure again on restarting, then you discontinue it. So that's the difference between the two. So I would say Active CNS disease, definitely no blina. Clear it first. Any neurological sequelae, look for alternative methods than blina. Use blina only as last line. There's a good chance you may have to stop the blina. CAR-T, clear the CNS before using CAR-T. If you can't, and it's an approved therapy, explain the risk to the patient and go ahead. You could, but definitely try to clear it first. Usually it does clear with TITs, so that's good enough. Non-CNS extramedullary disease, both CAR-T and BLINA are not highly effective. So local control of extramedullary disease is desirable prior to that. Having said that, each CAR-T is different and we see different characteristics. Though extramedullary disease was exclusion in the trials, patients who developed it while undergoing CAR-T or just prior to have cleared their disease and it's clear. So we don't know, it's a new therapy. We don't know how best to use it yet. But definitely extramedullary disease should be controlled as by in principle before you take for immunologically directed therapy. In principle, that should hold true.
The next question is also to you, sir. Would you consider in any situation taking a patient with MRD positive status to HSCT?
Should HSCT ever be done in MRD positive remission? ALL? Okay, so the data is very clear that the outcome is not going to be good. So the only situation where it becomes justified is there's really no other alternative. So you really need to ask yourself that, is there something else I can try to put into MRD negative remission before taking up a transplant? If really there's nothing left and nothing is feasible, then we'll go ahead. But the chances of outcome being poor are very, very high. So that is proven. So I think the only situation where it is mandated is back to the wall. Now you have options. Earlier, just 6 years ago, all we could do for these patients was flog them with more chemotherapy, which was anyway not working. So we used to do. We have done it all, and I have moved away from chemotherapy now. Even in patients, the moment we have identified that this is a potential candidate for blinatumomab or this is a potential candidate for CAR-T, in that chemotherapy regimen that we showed you, we take off mitoxantrone. No anthracycline in reinduction. Even bortezomib we'll avoid because we don't want neurotoxicity. We don't want cardiac toxicity. We don't want mucositis. We don't want the chance of patient dying of sepsis in induction when we already identified that he's going to be going for blina or for CAR-T later on. So we are very clearly moving away from intensive chemotherapy in second line and third line for patients once identified for immunotherapy. So much so, I think it was Swami only who was, when he was closely associated, and you saw he was the second author also in our CAR-T paper. And with the BHAP program, he was associated. Once he had remarked, he says, "Sir, these days we are preferring to treat relapse patients rather than upfront patients because the journey is so much smoother. They come in with the relapse, 70% blast, etc. You start them on chemo light, take them through induction, take them up for blina when they've got only 4-5% blast left. Okay, and MRD may be positive, and then you push them for transplant. They are running around the ward. What we used to see earlier, more and more chemo, ICU, this, that is all gone to a large extent. So we are much happier that way. Even in the situations where chemo and blina is not going to work, I would rather go for inotuzumab and bring the disease burden down smoothly, inotuzumab plus chemo, then take up for blina. We have started doing that now for relapsed refractory patients. So even that chemo backbone without mitoxantrone, we are not going for now. We are now more and more on selective basis going for an inotuzumab plus chemo, bring the MRD burden down, even eliminate it possibly, and then give some bridging and take for transplant, or take for CAR-T, or take for blina, and then later on followed up by transplant. Because by that time the gap between INO and transplant is also more than 3 months. Then hopefully the VOD is less by that time. So the whole game has changed. I would say there should be very little situation where you would need to do a transplant for an MRD positive patient.
So next question is to Dr. Sandeep. This is regarding the role of MRD in choosing the intensity of the conditioning in SPCTT. In adults, we often see that reduced intensity conditioning is recommended for the refractory relapsed AML, considering the treatment-related mortality and morbidity in this situation. Now, in the context of pediatric transplants, could you modify your AML conditioning strategy based on the level of MRD, and considering that there is so much variability in the standardization of MRD in our country?
So Raghu, I think in children and young adults, we always prefer to use myeloablative conditioning. Having said that, while myeloablative conditioning is regimen of choice for most of the patient, a subset of patients, particularly those with underlying genetic disorders such as Down syndrome, or those having leukemia predisposition syndrome, or those with inherited bone marrow failure syndrome with secondary AML, in these patients, chances of transplant-related mortality because of the toxicity is very high. In these patients, reduced intensity conditioning may be used. Another subset of patient where reduced intensity conditioning may be used for the patient undergoing second transplant, or those who are having significant morbidities. There, I would prefer to use reduced intensity conditioning. But if we look at the options that we have and we use most of the time in our AML patient, for a matched sibling donor, the two most common options are Buflu and Bucy. In the North American and also in the European protocol, they add melphalan to it also. We have to understand when we add melphalan, we increase the intensity of this myeloablative conditioning, and therefore the complication in the peri-transplant period is going to be very high. So we need to have very good supportive care infrastructure when we add melphalan. That is one thing. The other thing is dose of melphalan actually. If we look at the in patients with MRD positive pre-transplant, the dose is around 100 milligram per meter square, but in MRD negative patients, 70 milligram per meter square may be good enough so as to not to have too much toxicity. But despite in the European BFM protocol also, after using melphalan, their toxicity in the post-transplant period was very high, especially in children with more than 12 years of age. And in fact, in light of those results, now they are testing this Buflu with melphalan and TTF regime. They are having a head-on trial, and maybe in future we may have TTF as a treatment of choice other than Buflu mel in this subset of patients. Yes, MRD status plays some role in deciding the conditioning regimen, but one has to see how much intensive conditioning one can give depending on the supportive care infrastructure that one has. Because if you want to increase your survival by 10% and you lose 1 out of 10 patients because of toxicity, whole advantage is offset. So one has to keep a balance between these two things.
Next question is to Dr. Virendra. So, in case of patients having achieved CR1 in upfront treatment, what are the indications where you would take the patient straight away for transplant? Or would you, if you continue with further treatment and wait for relapse in the
Yeah, who should proceed with chemotherapy and who should go with the transplant. So, well, this topic was covered by Professor Gaurav sir just now about ALL indications of transplants very well. So just to brush off that is that all those patients who do not do good with chemotherapy and whom you think that the patients are going to relapse high are the one which are going to be the candidates for transplant, like those patients with T-cell ALL having poor prednisone response or induction failures, those patients with having bad cytogenetics and not doing good or positive MRD post in consolidation too. So that chunk of patients with ALL can be considered for transplant. And so coming to AML, in AML probably the things are much more dubious. What we say that of course high risk cytogenetics are pretty sure that you take up for transplants, but the patients who fall in intermediate risk, those are the patients who usually we think whether to do good with the transplant or no. And our personal experience has been poor with those patients who falling in intermediate risk pediatric AMLs. haven't done well with our chemotherapies backbone. So that is what our personal experience is. But of course, when the indications for AML, pediatric AML, we say that all those patients who have poor cytogenetics with poor response to the chemotherapy are straightforward indications for transplants in CR1.
Thank you. The question is for Vivek sir. This is specifically regarding Philadelphia positive UCP-ALL. Now, we often find that there is a discrepancy between flow cytometry based MRD and PCR based MRD for PH positive ALL. So post consultation, if you find such discrepancy, how would you proceed? Would you still advise the patient for transplant?
Yeah. So we'll go by the evidence. Flow cytometric negativity pH negative blasts in pH positive ALL at the end of induction should continue on standard chemotherapy. The evidence for that is decent enough by now, regardless of what other monitoring method you are doing. So if you want to go by the evidence, then probably you should drop your RQ-PCR monitoring, because the decision is not really based on that as of now. However, it can give you a good marker, especially if it is rising. So, especially a log increase in low-level disease should be taken note of as impending relapse. And you can switch your TKIs at this point. I would still not go for transplant, because now you got dasatinib now available for pediatric use freely in the country now. There was a period when it was not there, but only the fortunate few could get it. But now it's there, so you should consider. If you're already using dasatinib in your frontline therapy, then you have a issue. But if you get a decent level of transcripts which are rising, then you can do your mutational analysis. But it's difficult to do a mutational analysis in very low level disease. So how to interpret low level RQ-PCR positive in the presence of sustained MRD flow cytometric negativity remains a dilemma. We would not transplant unless there is flow cytometric evidence, especially now because we have got good therapies for second line apart from transplant, or even prior to transplant in this population. So a high risk, I would define the relapse by the standard risk criteria of relapse as low, standard, intermediate, or high risk based upon the timing of relapse and the sites of relapse. And if it becomes a high risk relapse, any pH positive relapse, we would consider for CAR T even at the time of first relapse, because the outcomes in second line therapy for pH positive ALL, even with transplant, are not that great as compared to non pH. So definitely this would become a candidate to consider for CAR T first, or for immunologically directed therapy, and for to be followed by transplant if transplant could clearly be proceeded within that patient. And this is the kind of patient which we would put a second generation TKI along with chemo reinduction, take up for blinatumomab, and push for transplant. If the patient could go for CAR T, take for CAR T. So this would be the strategy rather than transplanting in CR1, which as documented by flow cytometric negativity.
So in the context of persistent MRD positivity, low level MRD positivity, how feasible is it in our setup to keep on trying to achieve that goal of complete MRD negativity? Would you proceed for transplant in this situation, or continue to give multiple lines of therapy?
I think this question has already been covered by Dr. Gaurav, and I think things are totally different for ALL and AML. I think as Dr. Gaurav has clearly told, in ALL we have so many options now, and achieving negative MRD status, I think, should be aimed before transplant. There is no doubt about it. Be it like blina, inotuzumab, or whatever options we have, we should try to get a negative MRD status. But in AML, things are slightly different, because chasing a negative MRD may sometimes be counterproductive, and the patient may land up in fungal pneumonia or MDR infection, which can preclude them from getting transplant later on. And therefore, in AML, I would take a patient with low MRD and their we can still achieve a result of 20 to 30%, which is quite okay for a relapsed AML patient with transplant. But in ALL, I would definitely prefer to have a negative MRD before transplant, unlike in AML, where low borderline MRD may be okay and not subjecting them to very intensive chemotherapy to achieve negative MRD.
Yeah, that is one of the realities that we often face, especially with AML patients, as you said. Trying to, get into that level of MRD often comes at a very high cost, both in terms of morbidity and even the financial issues also. The patient may even forego transplant after achieving
Right.
those standards. So this is a more uncommon scenario where we have pediatric MDS patients with extra blast and or a case of AML. So what in this situation, what is the recommended disease control before the transplant?
Yeah, so this is special when we consider in the group of AML. So in AML, of course, you need to get the disease under revision as much as possible. And MRD negative also gives good results. But when it comes to MDS EB, you can probably straight away go to the transplantation if you're thinking that the patient has got less load of blast. If it is recommended is to get blast at least less than 10%. Probably going straight away with the transplant is also acceptable. And if the patient has got blast more than 10%, probably you can think of doing some hypomethylatic agents and get the load of the disease under control before go to the transplantation. So as the results have not been very influential, getting the disease under control or not, going into the transplant is more important rather than having some toxicities with the bridging therapy. So transplant would be indicated even if the disease is positive.
Back to Dr. Sandeep. In terms of the choice of donor, where we are preparing patient for transplant, would you say that, especially in our setting, haploidentical transplant to take the cell stage as the transplant are concerned, but registries are still expanding. So what do you think in terms of long-term outcomes? Would you still favor mass donors if they're available, or considering that excess cost that the family has to bear to get a mass donor? Or would you go ahead with the haploidentical?
I think this is one area where we have made a remarkable progress in last 1 decade. Number of patients undergoing haplo-BMT and number of the centers that are doing haplo-BMT is increasing day by day, and also with a decent success. Now in acute myeloid leukemia or in high-risk leukemias, the timing of transplant is very crucial. And the most, I would say, logistic issues in getting a mud graft is timely. Second, 8 to 10 lakh rupees of extra cost. And thirdly, it is only available to 15 to 20% of the patient. So these three factors always play a role in the mind of treating transplanter and has led to use of more and more haploidentical transplant. So besides logistic, if we look at the safety and efficacy, I think the graph for efficacy and long-term toxicity is converging with both the modalities now. And haplotransplant results are converging very close to mud transplants. If we look at the last published data from EBMT, wherein they have shown around 250 patients of mud transplant and 100 patients of haploidentical transplant, their outcome is almost similar. Only difference is that the grade 3, grade 4 acute GVHD is somewhat more with haploidentical transplant. Otherwise, cumulative incidence of relapses and the overall survival is almost similar. I think in today's time, it is a suitable alternative to mud transplant. Having said that, again, these results are from very controlled conditions. In our setting, we know that the supportive care infrastructure, experience of treating team, all that matters. But I think if we look at the literature, results are almost similar. But in our setting, we have to be very careful while choosing these two options.
I think we have time for one more question. It's to Dr. Virendra. So there are multiple lines of treatment being given to the patient, especially in the AML setting, including TKAs and hypomethylating agents. So what are the points to note regarding the continuation of these treatment modalities when you are taking for a transplant? When to discontinue these, and what are some of the specific toxicities that we should anticipate in during the conditioning based on the bridging therapy that we have used?
Yeah, so the basic principle of behind this is to avoid as much as possible your bridging therapies overlapping toxicity with your conditioning, one. And second, your bridging therapy should not be causing damage to the graft. So two important things that need to be noticed. And from that point of view, probably you can divide this and then see chemotherapy. Of course, when you give intensive chemotherapy to get the disease in remission before transplant, you need to wait for those metabolites to settle down before you go out with that. And second, of course, so it would be around 2 weeks to 3 weeks, depending on the chemotherapy that you used. When it comes to TKI maintenance, they have got very short half-life. Depending on the short half-life, you can decide about the timing when you would like to go to the conditioning. So some of the TKIs like imatinib, dasatinib, they have got very short half-life to 3 days to 5 days before conditioning. You can extend to that level too. So about the immunotherapy, already Professor Gaurav sir has highlighted that you need to give good gap between some of the immunotherapies like inotuzumab, which has got bad complications like SOS or VOD, what we say. So the gap which is recommended is around at least 6 weeks from the last dose of inotuzumab. So during that phase, probably you can substitute blinatumomab. That is one good option if the patient is affordable and drug is available. Or else even high-dose methotrexate or chemotherapies. So we do methotrexate, high-dose methotrexate or some chemotherapies to bridge and buy time to go ahead with the transplant. So by that, even that doesn't nullify the risk of having VOD. We still take a lot of precautions. We avoid or we probably modify some conditioning regime so that the patient do not get VOD as much as possible. But still, they do have some risk of having post transplant complications.
Thank you. Dr. Sunil, I think we have come to the end of the session. It's past 9 o'clock. Over to you.
Thank you, Dr. Raghu, and everyone here. I know we are beyond time, but I would want you all to take up these 3-4 questions are there, and I request you to be brief so that we can finish on time. The one question was on CNS labs. So there's isolated CNS labs with some MRD, which has been mentioned as 0.018%. What is the role of blina? So kind of very minimal marrow disease, but florid CNS disease can blina. I think you answered it partially, Dr. Gaurav, but you can, I think, probably reinforce it again.
Yeah, clear the CNS and give TITs, put on steroids and VCR, asparaginase. No need for anthracycline. It's already low-level disease. Clear the CNS and then you can take up for blina. And if you have an MRD negative remission, you don't need to go for blina. You can, if there's no blina available, you can go straight for transplant. But
so in summary, I think you're trying to say that blina, it's not a good CNS drug. So I think that's what we're trying to say.
Yeah. And
so
both
other question
for efficacy and toxicity.
Yeah. So I think Ajit has asked a question: is blin available through this program in the setting of MRD negativity post inotuzumab bridge to transplant? I don't think so under the program support program.
So relapse is defined as more than 5% blasts. Okay, has to be there if for relapse to be diagnosed, and refractory is defined as more than 0.1%. So
there should be some disease.
So those are the US FDA approved indications. So many times we find our patients who have relapsed but not meeting the criteria, so we are not able to use through the program.
Sandeep, before transplant in CNS positive ALLs, what is the role of CNS boost radiation apart from TBI? Is one of the questions.
So what we can do is sometimes we give cranial irradiation before the transplant, 18 gray, and then take them for transplant. And that is the one thing. The other thing is during TBI, we give extra boost to the cranial site up to 18 gray. So 12 gray TBI with extra boost to positive sites up to 18 gray. That is the other option that we can do.
And we prefer that option because, just to add on, if you do 18 before and then 12 as TBI, that becomes 30 grade to the brain, which
No,
is too
no,
much
no.
of
We don't.
radiation.
We generally don't combine
So
these
if
two
you
setups.
if
No,
you
no.
have to give a cranial boost, so reserve it till the transplant and use that as
Yes.
in with TBI 6+12
Right.
Same,
is being
yeah,
used.
better.
So I think Virendra, you discussed it already, washout period for inotuzumab before transplantation. So that's, I think, discussed already. But Virendra, one question is on P53 positive ALLs. Should you consolidate upfront? That means, I think, question is about CR1 transplant with CAR-T or transplant. So in these, if you're P53 positive.
And
Yeah, please go.
me?
Virendra, if you can take it, so or otherwise.
So germline P53 mutation with ALL, is that the question?
Yes.
Yeah.
Okay. So that is really tricky. So P53 with ALL and AML, definitely has got high risk disease and then can be considered for transplant, but need to be aware of the risk what it poses on its own for secondary malignancies. So that keeping in mind, probably even CAR T cell therapy is also one other option if the patient has got refractory disease.
Sunil, may I add something here?
Yeah, please.
In P53, with chemo alone or with transplant, the outcome is almost similar. It's 50%. So transplant has not actually added survival advantage in this specific subset. I think this is a subset where Blina is again going to be a game changer because we have not been able to improve outcome by intensifying treatment or by doing the transplant. I think Blina in this setting may be a game changer and may improve survival to other counterparts.
Dr. Gaurav?
Yeah, so I agree with Sandeep. And I will add that P53 I had already included in my algorithm earlier that we would rather prefer to take for CAR-T. We would avoid cytotoxic therapy. Blina also I would keep as second post CAR-T option because you still need to consider CAR-T Blina with the transplant preferably or with more chemotherapy. And I would not relapse in do it in CR1 because these patients do get repeated malignancies. If they are in remission, you can stagger your treatments. So no need to rush to toxic treatments. And definitely it would not be transplant in CR1, like Sadi pointed out.
Just to probe you a little bit more, if it's not a germline mutation, P53, then what do you do?
I think if it's not a germline mutation, just treat them like high risk ALL. The only
Yeah, I think MRD takes the precedence there and let MRD decide. They're poor players, even with non-germline, we know that. But I think let MRD take
the other thing that we
this.
should remember that if we are taking them for transplant, don't use TBI for these patients. This may be really detrimental.
The non-germline is pretty common to
fine, but germlines, yes.
Yes, for germline, yes.
Yeah. Okay, so I think we come to the conclusion of this very, very fascinating and interesting discussion which we had, and I want to thank each one of you for taking time out and prepare for this discussion today. And it was a very important discussion, and we touched upon very important practical points with regards to the most two common malignancies which we see in children, and how to manage the difficult ones. Thank you very much, all of you. Thank you, Dr. Venkar, for chairing this whole session, and most importantly, thank you, Satyendra, for putting this together every month. And it's not difficult to it's not easy to have all these stalwarts coming over every month and participating in these discussions. So thank you very much, and we'll see you again next month with another topic, and most probably the next one will be on cell therapy. We'll see you next month, last Tuesday of the month. Thank you very much, and have a good evening, everyone. And thank you everyone for participating and all your interactions which you had. Thank you.